Ladies and gentlemen, you are most welcome to this highly relevant and important session. My name is Henrik Petterson, and I'm honored to be here. I'm a specialist physiotherapist in cardiovascular diseases, and I work at Karolinska University Hospital, Stockholm, Sweden. I'm also affiliated to Karolinska Institutet. I have a PhD in systemic sclerosis, and I combine my research with clinical work at the rheumatology clinic. I do both research and clinical work at Karolinska. I focus on systemic rheumatic diseases with ILD. There will soon be several films available on the FESCA website, where I talk about the importance of physical activity, exercise, and several other important things and topics that are of relevance for you all. We will listen to 4 10-minute presentations, and after these have finished, there will be time for questions. So please use the QR code where you can ask your questions. So without further delay, let me introduce the first speaker, Maria Koulopoulou. I'm so terribly sorry. Maria is a cardiorespiratory physiotherapist and the clinical lead for the pulmonary rehab program at King's College Hospital in London, UK, with a specialist expertise in interstitial lung diseases. She is an internationally invited speaker presenting at conferences and professional forums on the role and importance of impact of non-pharmacological management in fibrotic lung diseases, including systemic sclerosis-associated ILD. Her work focuses on advancing the evidence base and clinical integration of pulmonary rehab within complex respiratory care. Maria has a strong interest in health policy and advocacy and is committed to strengthening access to and implementation of pulmonary rehabilitation as a core component of the fibrotic lung disease pathways. Please, Maria.
Thank you for the kind introduction, Henry. It is my pleasure to be here today and to have the honor to share my clinical experience and my academic expertise in this very interesting field of systemic sclerosis, and particularly when this condition affects your lungs. So my presentation is about how to optimize rehabilitation pathways for patients with systemic sclerosis, and particularly when the lungs are affected by lung fibrosis. So you are familiar, of course, with the term scleroderma or systemic sclerosis, and I would like to give you a little bit of a history, a background history around this condition. Scleroderma or systemic sclerosis is a systemic, multi-organ disorder. It affects more than one body organ. It is characterized by autoimmunity. The body goes against its own body cells, systemic inflammation, vascular injury, and tissue fibrosis. So this condition, it is not new in the forum of clinicians. It's been since the 5th century BCE, which was described by a Greek clinician, Hippocrates, as thickening a disease that is affecting the skin, by thickening of the skin, as wood-like. And then later on the 19th century, a Milanese clinician, an Italian clinician, applied the term for the first time, scleroderma, which is known to every one of you. The term scleroderma is derived by two words. And both of those are Greek. Scleros, it means hard tissue, and derma, which is the skin. And therefore, we have the term scleroderma, hard skin. I believe most of you familiar with the EULAR guidelines, or you may have heard that exist international European guidelines that update us about what is new in this condition, which treatments are available. And the EULAR has updated in the last couple of years. Actually, we have the new update more recently in 2025. What are the new available treatments? Not to cure, unfortunately, at this stage, but to improve and manage the diseased organs. And as we already said, this condition affects more than one organ, and even one organ can be affected by in different ways. We take, for example, the skin, where some of you may develop a Raynaud condition, this condition that affects the fingers, skin ulcers, or skin thickening, and we're talking for one organ only. The kidneys can be affected, the gastrointestinal system, but today I would like to focus on the lungs, where the lungs can develop. It seems that it doesn't fully work here. So the lungs can be affected by fibrosis, and it is expected that 20 to 30% of patients can develop fibrosis in their lungs to a variety of disease severity. It can progress to a very severe lung fibrosis in the lungs, and it can be a detrimental pathway for the patients. The lungs can also be affected by 15-20% estimate, also with pulmonary hypertension. And what we need to know about the treatments is, and for you to be aware today, what are the available treatments, pharmacological and non-pharmacological treatments that can help the management of these organs being affected. You're all familiar with this building. This is the Parthenon, right? I hope you will have the opportunity also to visit this architectural treasure. It is really breathtaking. It is also breathtaking to appreciate the efforts that were made to build this architectural treasure. It is also important to think today how much of effort is required to build such a worldwide wonder. So there were strong foundations, precise planning, technical expertise, and precision, most importantly. It took about 15 years for the building to be made in the 5th century BC. And what I would like to, the reason I brought this building up today is that if we want to design excellent clinical pathways for the systemic sclerosis condition, what do we need? We need strong foundations, we need expertise, we need planning, but we also need collaboration, co-designing this service. And we want these services, we want the pathway to be designed for the patients, not for the for the service providers, how the service providers want the service to look like, but how the patients want the service to be designed for them. So therefore, think today. Think how this service you want to be designed for you. What pathways are important for you? What part of this pathway will make your condition be treated easier and more effectively?
2 minutes remaining.
So clinical pathways, it's the whole journey that the patients go through from diagnosis. We want to get the diagnosis right. That's the most important thing. We want also to classify which states of fibrosis, what organs are affected. And because this is a multi-organ condition, we want excellent expertise to define to collect all the problems that are associated with your condition. Also, we need clinicians that have not only clinical skills, but also the right human skills, the soft skills that are combined with compassion, with time available for you to tell them exactly what matters to you. And they will never know unless you tell them exactly what the problems are. So it is very important for you to give your own contribution. And then we want follow-up appointments, timely given to the patients, and by the right expertise. There is here some variability across different countries. For example, in the UK, the follow-up appointment, it might happen by a specialist nurse, not from a doctor necessarily. In other countries, there's no question for the follow-up appointment to not be done by a doctor. So it is again down to you to discuss this in the service development. Whom do you want? It can also be a combination, but it is also your voice that matters, how you want to be followed up for your clinical journey. And then, because it's a multi-organ condition, we want all your problems to be addressed properly and to be referred to the right pathways and services that will address your problems, your symptoms, and your condition. And you want to know which are these available services that will make the difference for your condition. So it is important also here to voice and tell what do you want to be available for your service. We also have technological advances now that can prompt you with your symptoms to address problems and be referred to the services that are designed for your condition, like, for example, to be referred to a pulmonary rehabilitation program if fibrosis has occurred in your lungs. And
we have to keep up
I will
schedule.
Finish here with a patient-focused service should be reciprocally provided. So not only from the clinicians to the patient, but also the patient, which is in the center, to come across to all the clinicians who are expected to provide care for their condition, to tell them what they need and how things to become better. So I will close with this message: organ protection saves lives, symptom control restores living. And thank you for your attention, and I'm looking forward to hear your questions at the end.
Thank you very much, Maria. The next speaker is a German guy, Michael Oeschger. Michael has been living with scleroderma for 20 years. Early in the course of the disease, significant physical limitations forced him to step away from his work in logistic management. The long-term physiotherapy and consistent rehabilitation, he gradually regained mobility and is now able to work part-time again in logistic controlling. He holds a degree in business administration and serves as chairman of the German Scleroderma Association and chairman of the German Scleroderma Foundation. In these roles, he advocates for patient-centered care, early rehabilitation strategies, and empowerment through practical self-management. Welcome, Michael.
So, hello everyone. It's a pleasure to be here again at the World Scleroderma Congress. We are going to hear from Alain later on what is possible in physical therapy, and my role now is to bring you closer to the practical assessment of what a patient with scleroderma, living with scleroderma for a long time, has to do and did do to get from a status of not being able to move at all, nearly, to a much better status to be able to stand here and talk to you. So I have been living with scleroderma for 20 years, and today I would like to share what movement has meant in my life, not as a doctor, not as a therapist, but as I call it a power user of therapy. So 20 years ago, I was feeling very bad. I could barely open my hands. I could not bow. I could not put on my socks by myself. I could not bind my shoes. I could not even take one step of a stair. I was forced to lay down in bed most of the day. So life became a little bit painful. In the morning, my fingers felt stiff and painful. My whole body felt rigid. Daily tasks like buttoning a shirt, opening a bottle, or even eating with fork and knife were impossible. So, and more than the physical symptoms, I remember one feeling very clearly. It was fear. Fear about what would come next. Fear that everything would get only worse. Pain was all over my body, and I truly believe there is nothing I can do. I just have to wait and see what happens. So just a short wrap-up from a patient's perspective. We heard from Maria what happens in scleroderma. From a patient's view, the skin and the connective tissue become tight. The body feels like a cage. The structures from your toes to your fingertips shorten, and the joints lose mobility, and even the skin does. I describe my status as it felt like I was wearing a diving suit, which was one size too small, and lined out with sandpaper. So that's, I think, a description that is understandable. And there was one important thing I learned. When I stopped moving, the stiffness progressed even faster. So movement does not stop the disease, but lack of movement makes the consequences worse. My turning point was around 3 months after my first therapy. I received my diagnosis 15 months after the first symptoms, so relatively late, and there was already a lot of damage done. So I started regular physical therapy, 6 days a week at the beginning, and 3 different therapies. All of them was passive movement. I didn't move actively. I thought I wasn't able to move actively. So there was always a therapist moving me. And it was very frustrating at first. Progress was very slow, and sometimes I wondered if it was even worth it. So 3 years later, I added active movement to my therapy. So this was the first moment I felt able to do that. And I quickly recognized that active movement improved my mobility by 20% in between a very short time. So I continued to do this. And it does not cure, but it preserves your function. And most importantly, it gives you back control of your life and a better feeling. So a short interruption, what I have to add, it is not the movement alone, it's also the right medication. So it's medical supervision, it's regular monitoring. Please do not exaggerate, don't overwhelm yourself. Talk to your doctors, tell them what are you doing, tell them what you want to do, and keep an eye on your blood markers. That's what's just, I wanted to add that. So, exercises you should do, maybe I should change the word into you could do. This is what I do. So, I move every day. I move my hands, open and close fists, 10 to 15 reps or even more. I always work around with my hands. Do finger stretching, do gentle body stretching, use soft balls or any other instruments. Very important, do shoulder mobility, it helps you breathing, and do chest opening stretches, and be always aware of your posture, because your body tends to bend, and avoid that. So, I worked along the muscle chain. I said it before, from the toe tip to your fingertip, it is a long chain of structure, and it all is linked together. So every single movement has an effect on the whole system. And I became aware of that while training. So these two pictures I stumbled upon in a magazine, and I like them because they give me the possibility to tell other people what happened in my mind while I was training. So these pictures show a perfectly stretched structure. I'm not able to do that, but it gives me a motivation. I can think about when this is my goal, what do I have to do and where do I have to enter? What is the first step for me individually to do that, to reach this maybe? Can I put, for example, my foot on the ground like she does in a stretched way or in the other way? I can't. Why not? Because my toes don't bend enough. So I have to train my feet. I have to tell my physical therapist, I want to train my feet. Just an example. Can I put my hands together like she does? No, I can't, because my tendons are too short here. So I have to train them, and so on. So this is about mindset. This is about finding entry in your individual training. These two pictures show an anonymous scleroderma patient stretching himself and trying to take a position that he has seen in a magazine. So this is what scleroderma reality looks like. This is what it looks like when you go to your therapist or you do it at home. Also, the next two pictures, they don't look as spectacular as this picture in the magazine, but this is reality. Even the left picture doesn't look like stretching at all, but it feels like. So, this is my daily training for 15 years now. So, and let's be real, there are setbacks in the part of your journey. They will occur. Flares happen, fatigue always happens, motivation drops. I experience that very often. And if that happens, just adjust intensity. Don't stop completely. That's my advice to you, and restart gently. So, what I have reached after 20 years with scleroderma, I have a much, much better mobility. I wrote only the word much, much 2 times, so it would be better to have it written 8 times. Much, 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 much better mobility. More strength, more confidence, more flexibility. It was not a miracle. It was progress. It was consistency. That's the most important thing. Be consistent. Never stop completely. And finally, independence. Because at the beginning, I needed someone to help with my shoes. I needed someone to help with my socks. I needed someone to help with opening a bottle. For everything, I needed someone to help me. Now I can do everything alone again, and it feels really good. So start today, even if it's just a couple of minutes. Be consistent, don't be perfect, and your body will respond. Thank you.
Thank you very much, Michael. Inspiring talk. The next talker is Alain Lescoat. He is a medical doctor and scientist, have a PhD in internal medicine and clinical immunology. He currently serves as a principal investigation of the SSC cohort at Rennes University in France. Hospitals. In addition, he holds an appointment as adjunct associate research professor at the University of Michigan Scleroderma program under professors Dinesh Khanna and John Varga. Alain's research focuses on early disease pathogenesis and triggers, studied both in experimental mouse models and in at-risk population, that's pre-scleroderma. He also investigates innovative therapeutic approaches, including targeted therapies and cellular strategies such as CAR T cells and enzymatic stem cells. In parallel, he develops and validates outcome measures tailored to SSC based on the patient's perspective through a participative research partnership with patients. He recently led the systematic review for the EULAR recommendations on systemic sclerosis treatment, and he's co-leading the World Scleroderma Foundation ad hoc committee on pre-scleroderma. And he is a very proficient researcher with more than 100 publications in SSC peer-reviewed journals. So please welcome Alain.
So, hello everyone. Thank you very much for the kind introduction, and thank you very much for the invitation to the Patient Congress. I'm really honored to have the opportunity to talk to you today and to be here with you all. So the FESCA proposed that I discuss with you the positive impact of rehabilitation for patients with systemic sclerosis. So I'm not a therapist, I'm a physician and rheumatologist, but I will give you my perspective as a physician on what is expected from rehabilitation. I have no conflict of interest. So this is a busy slide, but it shows you the existing literature, meaning the existing scientific article available, which deals with the question of rehabilitation in scleroderma patient. What is important on that slide is that many fields, many domains, many symptoms that are the patient with scleroderma are experiencing can benefit from rehabilitation. You have hand function that can be improved. You have orofacial, you have cardiac involvement, pulmonary involvement, and most importantly, rehabilitation have an impact on health-related quality of life. So this is definitely an important part of treatment of a patient with systemic sclerosis. So we also have a specific recommendation that have been proposed by EULAR for non-pharmacological management of systemic lupus, but also on systemic sclerosis, providing key overarching principles and highlighting that all those non-pharmacological management, including rehab, should be tailored to the patient's needs, expectations, and preferences. And I think this is very important because this means that rehabilitation will be different depending on the patient, depending on the symptoms. So it should be really tailored to each patient. Rehab may comprise one or more interventions, so several exercises can be useful. Non-pharmacological management, including rehab, may be provided alone or as an adjunct to pharmaceutical treatment. So you can have obviously both. And rehab may not substitute for pharmaceutical treatment when the latter is required, meaning that you should continue to have a pharmaceutical treatment if you need one. So what about the management of scleroderma? So I've highlighted that specific part of the recommendations, which says that in people with systemic sclerosis, orofacial, hand, and aerobic and resistance exercise should be considered for improving microstomia, hand function, and physical capacity, respectively. So all of these domains, all of these symptoms can be improved by rehabilitation. So then I have selected a few scientific studies to try to show you why exercise is important, but most importantly, why continuing exercise is very important. So this is a French study, because there are not a lot of studies demonstrating the efficacy of rehab, and this one is especially, I think, interesting because it shows that if you do not continue the exercises, you will lose the benefit. So they have proposed a standardized supervised physical therapy sessions with the objective of the program being to increase the range of motion of impaired joints, increase muscle strength, increased aerobic capacity, and decrease mouth microstomia, skin retractions, and limitations in activities and restriction in participation. So there were 3 weekly sessions of 3 hours, each for 1 month. And then the patient were told to perform the exercises at home for 30 minutes daily for the next 12 months. And what the results shows that is in the physical therapy group, there was an improvement of the symptoms, but this improvement was only persistent in patients who continued the exercise throughout the whole study period. Those who stopped, who were not compliant, came back to the previous status, meaning that if you stop exercising, you will lose the benefit. And this is a scientific demonstration of that very important statement. So there are a lot of ways of exercising, and there are the group from Michigan is testing many ways to improve, especially upper extremity in scleroderma patient, using dedicated apps, using sometimes video games to help you use your fingers, because using a funny, I would say, tool will help you to keep motivation and to stay motivated to perform these exercises. There is also a peer monitoring program using an app to have other patients helping you in staying motivated. And I think that is a very interesting way of seeing rehabilitation and everyday exercises, that you are all in the same boat, I would say, and that other patients can help you to stay motivated. And I think these kind of peer mentoring programs are very interesting to help you stay motivated. And they also have designed a specific program and using both an app on your smartphone and physical therapy exercises to help you improve upper extremities. And we are still waiting for the result of these control trial, but it's to show you that there are a lot of different possible exercises that can help you improve, for example, hands function. So my take-home messages are that in patients with systemic sclerosis, orofacial, hand, aerobic, and resistance exercises are recommended. And this is part of the EULAR recommendation, so this is important. That there is a need for tailored exercise for each patient. So you are all different. You have all your own scleroderma, your own symptoms, so you will need your own exercises that will help you. Sustained exercise is needed to ensure long-standing progresses. So I think this is the most important message. You need to keep practicing if you want to keep the improvement and the benefit of the exercises. Non-pharmaceutical therapies should be considered in combination with pharmaceutical treatment when appropriate. So do not stop your medication because you are exercising, but please continue both sustained exercise and taking your medication when it's appropriate.
2 minutes remaining.
Yeah. So thank you for your attention. I really want to thank all the patients from the scleroderma program at the University of Michigan, but also the patient from my unit in France. And I really want to thank again the FESCA and the organizer for inviting me to deliver that talk. Thank you very much for your attention.
Thank you very much, Alain. The next and final presenter will be Kyriaki Keramiotou. She is an occupational therapist and president of the Palhenic Association of Occupational Therapists here in Greece. She is also head of the occupational therapy department at Triasio General Hospital in Athens. She holds a PhD from the Medical School of the National and Kapodistrian University of Athens and a Master of Science in Hand Therapy from the University of Derby, UK. She teaches at the University of West Attica and in postgraduate programs, and her work focuses on upper limb function and orthosis, with a particular interest in autoimmune rheumatic diseases, including systemic sclerosis, which aligns with the theme of this Congress. So please welcome Maria. No, Kyriaki, sorry.
Thank you. Good morning, everyone. Okay. I am an occupational therapist, and today I will talk about how occupational therapy can help people with systemic sclerosis protect hand function, manage daily challenges, and stay as independent as possible. In systemic sclerosis, the hands are often affected very early. Changes in the skin, circulation, and joints can make movement harder, and stiffness, pain, and fatigue can turn simple daily tasks into tiring or painful activities. Many people notice this in small things first: buttons, opening containers, writing, cooking, or using a phone. When hand function changes, the impact is not limited only to the hand. Self-care becomes harder, household and work tasks may be affected, and confidence, independence, and quality of life, finally, can decline. It is frustrating when you want to do things the way you always did, but your hands and energy do not cooperate. Occupational therapy focuses on function in real life. Our goal is to reduce effort and strain in daily tasks, protect function, skin, joints, and circulation, and support meaningful activities. In simple terms, we help people do everyday tasks with less pain, less effort, and more control, so that daily life feels more easy. This is exactly where prehabilitation and rehabilitation connect. Prehabilitation means we do not wait for severe loss of function before offering support. In systemic sclerosis, early strategies can help protect hand use and daily routines before problems become overwhelming. Rehabilitation becomes important when difficulties are already present, helping people manage symptoms, adapt activities, and stay engaged in everyday life. The key message is support should start early and continue as needs change over time. Gentle, regular movement can help maintain hand mobility and reduce stiffness. The goal is not to force movement, but to keep the hands as functional and comfortable as possible. Think small and consistent rather than a lot at once. Short sessions done regularly are often more helpful and better tolerated. Exercise should always be adapted to symptoms and tolerance, especially on days when pain, fatigue, or Raynaud is worse. In occupational therapy, small practical changes can make a big difference. We use strategies such as warmth, joint protection, easier hand position, and reducing unnecessary strain during daily tasks. For example, we try to avoid strong pinch and forceful grip when possible, and we choose positions that reduce stress on painful joints. Daily self-management matters. Simple habits like keeping the hands warm, pacing activities, protecting the skin, and taking breaks early can reduce strain and make daily life more manageable. A useful idea is to rest before you crash, not after. And pacing is not laziness. It is a strategy that helps you keep energy for the activities and roles that matter most. Simple assistive devices can reduce the force needed for everyday tasks. These tools help protect the hands, reduce fatigue, and make activities like preparing meals, eating, and opening containers easier. For many people, a jar opener or a built-up handle can be the difference between doing a task independently or needing help every day. The good news is that many of these tools are affordable, easy to find, and easy to use. Personal care can also be made easier, safer, and less tiring. Button hooks, zipper pulls, and easy fasteners support dressing and reduce the need for fine finger movements. Adaptive clothing can reduce hand strain. Sometimes small changes make a big difference. For bathing, pump bottles reduce grip force, long-handled sponges reduce strain, and simple bathing aids can improve comfort and safety. Work and technology also can be adapted. Ergonomic keyboards and mice can reduce strain during computer use. Hands-free headsets and voice-to-text tools can reduce repetitive hand use and help people stay productive with less hand stress. Many people are surprised by how much energy they save when they use voice tools for messages, notes, and emails. In selected cases, a hand splint may help by supporting comfort, positioning, and joint protection. Some splints are used mainly for rest and comfort, while others support the hand during specific tasks. However, splints must be individualized and reviewed regularly, and they should be monitored closely, especially when the skin is sensitive or fragile, so that pressure areas and irritation are avoided. The purpose of rehabilitation is not only to improve movement and function. The real goal is participation and independence, helping people continue their roles at home, at work, and in the activities that matter to them. Sometimes the biggest success is not a perfect hand, but being able to cook, dress, work, socialize, and live with more confidence and less struggle. To close, I want to emphasize that you are not expected to manage everything alone. Small changes, warmth, pacing, gentle movement, the right tools, and sometimes a splint can reduce strain and make daily life easier. Occupational therapy helps turn daily challenges into manageable routines so people can protect function and maintain independence. And this is how occupational therapy supports both rehabilitation and rehabilitation in real life. Thank you very much.
Thank you very much, Kyriaki. And we have a couple of minutes left for questions, and we have received some, used the QR code, and I will summarize two of those into one question. Which exercises are adequate during flares, fatigue, and pain? And also add, which exercises are recommended for SSC, SLE, myositis overlap patients with reflux, Raynaud, and muscle weakness? Do any of you want to answer that, or may I?
Please go ahead.
Thank you. I would say, as we have heard from Michael and also from Alain, you need to do something, and everything is better than nothing. So depending on how much fatigue you are suffering from this particular day, you try to adapt and do what is economically affordable for you in regards of the fatigue. Everything is better than nothing. So if you may take a short stroll, a walk around the house or the block, excellent. Try to do that. If you have some energy to do your stretching exercises, that we know that it's very important for maintaining hand function, do that. If you also can do a full body stretch for 10-15 minutes when you are having a rest laying in bed, that's also very good. In regards of reflux, that's a problem, and I tell my patients in the clinic that try to do the exercises before eating so that you don't feel bloated in the stomach, because it's very inconvenient to try to do a sit-up when you push your belly and you get a reflux. So instead, do it in an empty stomach. And one way to lower the risk of having a reflux is to do it, the sit-up in the sofa. And you can make a little bit of pillows laying behind you, and then you do a small, gentle sit-up. So you don't have to lay on the floor and do a full sit-ups like this. As long as you tighten up your muscles and feel that you are working, that's good. Muscle weakness is something that we all, even us who are relatively healthy sitting at the podium, we also need to do exercises on a regular basis. The one exercise, if I have to choose to give to my patient, that's the exercise that I think is fundamentally most important. Just do a slow and gentle rise up, and an even slower sit down. And I want you all to do this. Just stand up like this. And slowly down. Why is this so important? Well, it's a functional movement. We all lose muscle strength and muscle endurance by being inactive, forced by disease or a sedentary lifestyle. By doing this kind of exercise, you maintain and improve your muscle strength in your legs, which make it easy to go to the toilet, get up and down from the couch or the sofa, in and out from a car without having help from someone else. Adapt and do something. What you do is not the important thing, but you have to be active.
If I may add something, Henry, here, which is thank you for your insight and your experience bringing here today. But what is very important as a message to communicate today, it is very, very important patients to be referred to structured rehabilitation programs, because only if you are referred in a structured rehabilitation program, you will be able to familiarize yourself with the right exercises. You will have the guidance of the expert to understand what is right for you and what is not right, how much to push your body and how much to protect your body from a harm. And also, by exercising under an expert, you will learn your body better. You will understand what is right and what is wrong for you, for your own individual body, not generic advice. So this is so important, and that's why we have to get it right. You have to be referred to a rehabilitation center and rehabilitation expertise to guide you what to do right. And another thing that is also important here is that when you are under the radar of an expert center, there are things that it might be a flare-up of your condition that shouldn't be overlooked. And when you're at the expert center, that will be communicated to the multidisciplinary team. So, for example, it might be required a change to your medication. It might not be something that we should overlook. It might be something else, another organ that is coming into interplay of your condition, and you need to be referred or needs to be discussed in the MDT because something else intervenes now, and that's why you have a flare-up. And all these things are important because in a rehab center, it is not just one thing that is addressed. It's all the problems that contribute to have this. It can be many problems that can contribute to have this flare-up. And this is so important, and it has to be part of your comprehensive, holistic management.
I want to add something to the muscle weakness topic and to the the bad days you have and which exercises are suitable. I have an overlap syndrome with polymyositis, so muscle weakness is one of my symptoms. And I was very careful at the beginning because I have been told that I would not be able to gain muscle mass again. This is completely true. And but what I can train is muscle strength and muscle stability. So my muscles don't grow anymore by training like with normal people do, but they get stronger. And this is an improvement itself. And I watch my blood markers, I watch my CK level, the inflammation markers in my blood, and when they are okay, sometimes they go up after training, but when they go down again, everything is okay, everything is normal. When they stay high, I have to talk to my doctor. So that is one thing. I even started going to the gym 1 year ago, and I go to the gym 3 times a week. And every time I do the same exercises for 1 year now. And I noticed that this consistency, I don't raise the weights. I always keep the same weight. I always keep the same exercise, but the consistency does an improvement, and it did not harm my muscles while having an overlap syndrome, and my blood markers are still okay. So it seems to work. And just a short tip: when you want to do sit-ups and you have a reflux, you don't have to do the sit-ups with your upper body. Just lay your upper body as you feel comfortable and do the sit-ups with your legs. Just stretch them and pull them. Yeah. So this is. That's what I wanted to add to that topic.
Thank you. We have another question. How soon after diagnosis should I start physical therapy?
Immediately.
I would say immediately.
As soon as possible.
The longer you wait, the more the disease will impact your well-being and your functional capacity. We have a saying from the physiotherapy side, use it or lose it. If you have an ability that you don't regularly use, you will lose that ability to perform. If you want to be able to maintain a good life, in a sense, you have to actively do stuff. It's not enough to sit in the coach and do a slow walk. You need to do more to get better. And that will be my final remark, because the clock is ticking and there will soon be lunch. But before I let you go to lunch, I would strongly say that don't go away, because after the lunch there will be this session, VIDOS, the present and the future of early SSC diagnosis, where the speakers Beata Garay, Marco Matucci, and Monica Holmner will talk about this also very important thing. So thank you very much for attending, and thank you for all your inspiring and insightful lectures. I hope to see you all in Florence again within 2 years. Thank you very much. And don't forget to check the FESCA website, because there are soon to be published several films about the importance of physical activity and exercise and stretching, both very informal but also very educational films. Thank you.
Can I say one more thing?
Yes.
Yeah. Can I say one more thing? There was a question in the chat. Which were the 3 therapies I did at the beginning? So I just want to say the standard ones are lymphatic drainage is very important. The second one was manual therapy, and the third one was hand therapy. So I started with these 3, and I continued with having more of them. Now I have jaw therapy in addition, and breathing therapy. So at the moment I have 5, but I started with the standard 3, lymphatic drainage, manual therapy, and hand therapy.